My name is Dr. Kenneth Koval. I'm an orthopedic surgeon that specializes in trauma, and I work in Gulfport, Mississippi. So the patients that come in with high energy injury, that's a trauma activation. So they come into the trauma slot, they're evaluated and seen by a team of ER and trauma surgeons who then decide on the next course of action for the whole patient. Once the patient has been deemed surgically and medically stable, they will then call on the orthopedic team to deal with their musculoskeletal injuries. When a patient comes in that's multiply injured, we have to decide, prioritize how to treat their musculoskeletal injuries. Normally the pelvis and femur injuries are treated first, followed by other long bone injuries. Certainly the treatment of an AC separation or clavicle or scapular or proximal humerus is not an emergent and can be treated several days later. The question was, can you ever see an AC separation without a clavicle fracture? And the answer is yes. Most AC separations occur in isolation. However, you could have a complex injury with a clavicle fracture associated with an AC separation. I think for most part, the more severe ones, the ones that have significant displacement or posterior displacement, they're the ones that are treated operatively. The simple AC separations are just a fall or a sporting injury. The ones that are more complex involve either a fall from a height or a motorcycle or motor vehicle accident. For AC separations, one generally uses the near classification, where type 1 would be non-displaced, 2 would be partially displaced, 3 would be 100% displaced, and then the 4, 5, and 6 are the ones that would be operated on with 300% displacement or posterior or inferior displacements. The treatment of distal clavicle and AC separations is still evolving, and the treatment is somewhat controversial. The operative choices to treat AC separations usually come down to two choices. One is either a hook plate type device or a tightrope type device, which then stabilizes the clavicle to the coracoid. I like using the hook plate because I'm a trauma surgeon, not a sports medicine surgeon. It's simple to do, it's quick. It's just a matter of reducing the AC joint, stabilizing it temporarily with a pin across it, and then putting the plate in. The disadvantage is that the plate has to come out at about 3 months, and the plate can also cause irritation. The advantage of the tightrope type device is that it doesn't go across the AC joint. It doesn't interfere with the patient's shoulder motion, and there are good reported results using the tightrope. The disadvantage is that if you're not a sports medicine doctor and you are not used to performing arthroscopy of the shoulder area, then to me it's more of a complex type surgery, which takes a lot longer to do. For a hook plate set, it's imperative to have a range of options in terms of plate lengths and hook lengths. Plate length is important because you want to be able to span the fracture or the AC separation. The hook length is very important because if the hook is not of the appropriate length, either one, it'll protrude too far down into the subacromial space, or if it's too short, then you won't be able to place the plate down against the clavicle. I like using the Acumed hook plate. The main advantage of it, besides fitting well and having multiple screw options, is it has a template that allows you to determine plate length as well as hook length. Otherwise, you end up just putting the implant in and looking at it, and if it doesn't fit well, you take another implant and put it in there. Then it's more of a trial and error type situation. I think it's very important that the set for the clavicle and AC joint has multiple options and can treat the myriad of injury patterns along the clavicle and acromion.